won't change. We're looking at a future that is more like the past, more like the time when infections might lead to complications, suffering, or even death. Fortunately, there is still time to act. Antimicrobial resistance, ineffective antibiotics, call for interdisciplinary measures. And today we're placing a spotlight on this by exploring how the behavioral, the cultural, the social sciences and dimensions can help reduce the escalating threat of antimicrobial resistance. We have an amazing list of speakers for you. We have extensive engagement of you as an audience planned. We have an optional Ask the Expert session at the end, so you can ask as many questions as you would like to, and we hope you will enjoy it. Before we proceed, I want to share a few practical points. First, we want to let you know that we're recording the event, and for our regional committee delegates, I also want to say that this is an open event. It's not restricted to member states, non-state actors and partners. Second, we will be asking you to engage via polls and responding to questions throughout the event. And this is not only because we want to hear your views, which we do, but it's also because behavioral science has taught us that having a bit of time to take notes or reflect a little bit after hearing a presentation supports our understanding of what we've heard, as well as our knowledge retention. So please use these engagement elements between the presentations as your time to reflect on what you've heard and how it's relevant for you. Please also let me encourage all of you to now turn on your cameras, to include both your name and your country. It's really the only way that we can see who's in the room and we can share this sense of community despite being together only virtually. And then one last thing. You will be hearing two acronyms today, AMR, antimicrobial resistance, and BCI, behavioral and cultural insights. Some of you may not be familiar with these acronyms, so we're including a couple of definitions in the chat. With this, please let me hand over to Dr. Hans Kluge, Regional Director of WHO Regional Office for Europe, to formally open this side event. Dr. Kluge.
Thank you very much, Katrina. Dear Excellencies, Her Excellency Dr. Akmaral Al-Nazarova, Minister of Health of Kazakhstan, Dr. Pamela Rendi-Wagner, Director of the European Centre for Disease Prevention and Control. I also see Excellency Deputy Minister of Health of Georgia, Dr. Tamar, distinguished delegates, colleagues and friends. A very warm welcome to this Regional Committee side event on using behavioral and culture insights to address antimicrobial resistance, or AMR. The threat of ineffective antibiotics and antivirals is not some distant risk. It is already impacting millions of people. Victoria Panzari from Moldova is one of them. An inflammation of her pancreas became a life or death battle. The antibiotics failed. She spent 2 months in a drug-induced coma and underwent 10 surgeries. Only after multiple investigations were experts able to find an effective treatment. Victoria survived, but many others do not. And there are countless stories like hers. And unless we act now, there will be millions more. Current projections indicate that 39 million people could die from AMR over the next 25 years. That's 3 deaths every single minute. Is this acceptable? Absolutely not, especially when we have the power to change it. Colleagues, a key element in the fight against resistant organisms is behavior, and we know this. Hospital staff disinfecting equipment and isolating patients. Doctors prescribing antibiotics appropriately. and patients taking antibiotics as prescribed. There are behaviours that ultimately can save lives. At WHO Europe, AMR is at the top of our agenda, steered by our new roadmap, which we developed together with member states. I myself, 2 weeks ago, went to New York to attend the high-level meetings at the UN General Assembly on AMR. And I want to thank here really particularly Sweden for hosting an amazing side event on AMR at the Swedish Permanent Mission in New York the day before the UN high-level meeting. Dear colleagues, at the same time, our continued work with behavioral and cultural insights is helping to bring this roadmap to life, making sure we always put people at the center. The UN high-level meeting on AMR called on the heads of state, the heads of government, to step up the efforts. Another key call was about the interdisciplinary approaches, which will be crucial if our efforts are to succeed. I reiterated these very messages at all the high-level meetings at the sidelines of the UN General Assembly. I also announced, together with the director, Mr. Rob Butler, a new AMR accountability index for Europe and Central Asia to benchmark member states' progress and to support them in the response to tackle it, a kind of what I call a soft benchmarking tool. We will keep bringing together experts from different fields of science and disciplines to share how behavioral and cultural sciences can be harnessed to reduce the AMR's devastating toll. In the end, it's about the people. It's about Victoria in Moldova and the millions of others who are suffering needlessly. 3 weeks ago, for the 6th time, I was at the front line in Ukraine, and I'm very concerned when the doctors, the nurses were telling me about the war wounds that are becoming untreatable. The insidious increase of AMR in conflicts, be it in Ukraine or in Gaza, Israel or Lebanon, should not become the new normal. AMR is taking a devastating and preventable toll. So, my colleagues, let's act together with the tools, the know-how, and the innovations that already exist to make sure we do not fail the people. Thank you.
Thank you, Dr. Kluge. And we will be hearing, of course, about the devastating situation in Ukraine later on in this event. And the idea of 3 people dying because of AMR every minute for the next 25 years really seems quite devastating. Absolutely. So thank you. Before we proceed to the next part of our opening, it's time for our first engagement of the audience. It's a poll, and it should be open now, so please start voting. Please see the instructions in the chat. There's a QR code. You can use your phone, you can use your computer, and for this first question, we will give you a bit of extra time to respond, so you can explore how to best connect. Our first question is at the global level, and the question is enough being done at global level to address the threat of antimicrobial resistance? Simple question, yes or no, is enough being done? I want to say, of course, your answers are 100% anonymous. And as I said earlier, this is an opportunity for you to reflect on the topic. It's not a scientifically robust survey. It's really just for us to gauge who's in the room and what your perceptions are. And I'm looking at the results here, and it seems to be a very clear message that the answer is no, not enough is being done. Right now, we're at 85% saying not enough is being done. So I really want to get back to you, Dr. Kluge, and ask for your reflections on that question, but also on that answer that not enough is being done.
Probably you want to know, Katrina, what I would have voted. So actually, I would have voted no, but, because, you know, I'm a born optimist. So I think we should first and foremost acknowledge the many people who are working all their life on AMR. And I think a lot has been accomplished, but the figures speak for itself. We know that, for example, in the next 10 years, with a status quo, life expectancy will decrease with 1.8 years due to the AMR. I mean, that's unacceptable, really. So we discussed this actually quite a bit, Katrina, with Rob, with Danilo and the AMR team before going to New York, because I didn't want to tell in New York what we're telling already the last 10 and 20 years. If we know what works, then what is the gap between knowing and doing? So one point is that the majority of our countries have national AMR plans, but they're not financed. I think it was 4 on 10 of the plans are financed. So if you don't finance your plan, then actually there's not so much political commitment. But this leads to the next point, that money is short. A lot of money goes to defense. A lot of money goes to compensate for the cost of living. So we have to be smart, right? How to communicate. Actually, this was a main point when we had the event at the Swedish Permanent Mission in New York about, and I know you're working on this, and I think we're going to hear about this, the lexicon, the terminology. I always say, I have my neighbor, I have a great neighbor in Denmark, I'm very fortunate. He works a lot in the garden like me, and he had cut his finger. So I told him, I said to be careful, right, for the AMR. He was not interested. But when I told him, he has to be careful not to have a super bug to lead to amputation of his finger, this is a language he understood, and immediately he was very interested what RDWHO Euro is doing every day. So we have to communicate to the people and responsibilize them on AMR. At the same time, speak to the high-level policymakers. But it's a fascinating question. Thank you.
Thank you very much, Hans. And it is indeed a very good point on the terminology and the words we use. We tend to speak a language between us that we all understand with our acronyms and talking about resistant bacteria. But what does that really mean for individuals, for people's real lives? And we're definitely not good enough at doing that. And even in this event, we're using acronyms. We're talking about BCI and AMR. And I just want to say that for those of you who may not be familiar with these acronyms, we did put definitions in the chat, so you can always go take a look at that. Well, hopefully there is a way forward, and that's of course what we're here to try and find out today. With this, I would like to continue to the next part of our opening session by giving the floor to Her Excellency Dr. Akmaral Al-Nazarova, Minister of Health of Kazakhstan. Please.
Dear Dr. Hans Kluge, dear colleagues, esteemed delegates, I am the first Vice Minister of Healthcare of Kazakhstan, Timur Sultangaziyev, speaking on the behalf of the Ministry of Healthcare of Kazakhstan. It's a great honor and it's a great pleasure to be here participating in this very crucial side event on antimicrobial resistance and how behavioral and cultural sciences can help address this escalating health issue. Antimicrobial medicines are vital to prevent and treatment of infections of humans, animals, and plants. However, resistance to these medicines is threatening the sustainability and resilience of our health systems, jeopardizing the ability to achieve universal health coverage and achieving sustainable development goals. In fact, AMR is among 10 major global threats to humanity today. We know that the development and spread of AMR is accelerated by the human behavior. Also, we know that if we don't understand these behavioral behaviors profoundly, it is difficult to address them in effective ways. This is why behavioral and cultural insights are so important. In Kazakhstan, we have taken several measures to address these challenges of AMR. We hosted 73rd WHO Regional Committee for Europe a year ago, where health ministers and delegates from 53 member states endorsed the new European roadmap on AMR. This roadmap supports countries in the region to identify, prioritize, and implement high-impact interventions to tackle the AMR. Also, with the support from WHO Europe, we have conducted a pilot study in Kazakhstan to explore drivers and behaviors to pharmacists' behavior of selling over-the-counter antibiotics. We used the WHO Europe tailoring AMR programs approach to reach robust evidence. I believe everyone in the audience today will be able to identify challenges with AMR-related behaviors in their country. Challenges that involve doctors, nurses, veterinarians, pharmacists, patients, or other members of public engaging in the behaviors that drive the further escalation of AMR. It is our responsibility as health leaders to enable, support, and promote positive behaviors that reduce AMR. Please join me in wishing us all a fruitful and inspiring side event on this important topic. Thank you very much.
Thank you very much, Dr. Sultan Gaziev, and thank you for stepping in for the Minister of Health, Dr. Akmaral Al-Nazarova. Thank you, and sharing these important reflections from Kazakhstan. Now, let's dwell again a little bit on the topic of today and how it relates to all of us. So please pick up your phones or look at your computer to engage. There are instructions in the chat on how to engage in the question. And we have 3 short questions for you this time about your own personal engagement in the topic. Again, your answers are anonymous. The first simple question is, how much do you know about antimicrobial resistance and how it can be mitigated and addressed? So quick question, how much do you know about antimicrobial resistance? And I can see we have diversity in the room, quite a bit, moderate amount. So most people actually know about the topic, and very few people in the room say they know very little. So that's encouraging that most of the people who are in the room actually know what the overall topic of today is. So the next question we have is whether you're currently involved in projects related to antimicrobial resistance. Are you involved in projects related to AMR? Yes or no? And again, we can see that the majority in the room actually works with antimicrobial resistance. 85% of everybody who's in the room works with this topic. So that's quite encouraging. We have people in the room who have a lot of experience in the field. And the last question is whether you are involved in projects that are related to AMR behaviours. So is anyone in the room involved in projects currently that relate to AMR behaviours? And we can see that not as many people are involved in projects that relate to AMR behaviours. It's almost 50-50, but actually we've got more on the yes side. It's shifting a little bit, but it looks like half of the room actually works almost on AMR-related behaviours. So we've got clearly some diversity in the room. This is what we hoped for. This is what we expected, given the interdisciplinary nature of today's topic. And now, please let me proceed to the last speaker of our opening session, Dr. Pamela Rendi-Wagner, Director for the European Centre for Disease Prevention and Control.
Yes, hello and a heartful good morning from Stockholm, the European Centre for Disease Prevention and Control, dear Regional Director, dear Hans, dear Minister, and dear delegates. Undoubtedly, antimicrobial resistance is a huge challenge. Each year in the European Union, more than 800,000 people contract antimicrobial resistant infections, and more than 35,000 die as a direct consequence of these infections. But the good news is that Eurobarometer surveys have shown that public knowledge of AMR has slowly increased. However, the bad news is that this progress is far too slow, and it does not address the situation in healthcare settings. We at the European Centre for Disease Prevention and Control, we see that AMR is increasing, particularly in pathogens responsible for healthcare-associated infections. Although there are a few promising new antibiotics under development, with currently available antibiotics becoming less and less effective, we are indeed running out of time. Healthcare is under threat from AMR. This is an existential problem with no simple quick fix solution. But how did we get into this situation? We have a good range of effective interventions that we know that can minimize the development and also the spread of AMR. We know that strong infection prevention and control, for example, in hospitals and long-term care facilities can prevent and control AMR. We also know that encouraging patients to follow their doctor's advice and complete the antibiotic treatment works. We know that minimizing unnecessary antibiotic use in hospitals, such as the prolonged surgical antibiotic prophylaxis, can work. So why are we facing such a crisis? Well, one of the key reasons indeed is the suboptimal implementation of this knowledge, implementation of these necessary interventions. Hand hygiene. It is a simple and effective action, but ensuring that all healthcare workers clean their hands when needed requires a range of behavioral and social factors. And the same applies to the misuse and overuse of antibiotics, which are understood as being the major drivers for AMR. Changing behaviors requires much more than simply providing people with information. Knowledge is always part of the solution, but ultimately to address AMR will only be fully effective if social context and behavioral factors are properly taken into account. This means that people have the capability, the opportunity, and that people feel properly motivated to behave in a way that keeps.
Apologies, we have lost audio from the European Centres for Disease Control. We cannot hear the speaker.
Okay.
Thank you. Now we can hear you
Oh,
again.
you can hear me again? Okay, I start
Yes.
here again.
Thank you.
Well, these important sciences can identify the drivers and barriers to specific health behaviors. And importantly, they can give us insights into the supply and demand sides of antibiotics. Supply being the healthcare workers and our health systems. Demand being patients and wider community. Through this, they can not only give us a comprehensive overview of areas that Sorry, I guess you have lost me again, or I have lost you.
Yeah, but now we can hear you again. Thank you for changing the
Okay,
microphone.
sorry, I don't know where it really cut off, but I tried to find the point. Well, demands are being patients and wider communities. And through this, we can not only give us a comprehensive overview of areas that may be suitable for intervention. These sciences can also support their design, implementation, and evaluation. Social and behavioral sciences, or behavioral and cultural insights, are an underutilized tool in public health. So what is needed? Countries need support in building their capacity and engaging with communities to conduct this all-important social and behavioral scientific work. ECDC and many partners, including the WHO, member states, NGOs, and patient groups, are now stepping up to enhance capacity in this area. Collectively, our aim is to ensure that only the most effective interventions to address AMR are designed and implemented. The full capacity of every available tool, including the social and behavioral sciences, need to be included in our efforts to keep antibiotics working also in the future. And this requires an investment from all partners, as Hans has already pointed out. If done wisely, this investment will more than pay back for itself in the years to come. We will all benefit, and some of us very directly. It is only through a truly multidisciplinary collaboration that we will manage to keep the threat of AMR at bay. Thank you for your attention.
Thank you, Dr. Randy Wagner, for this powerful statement from the ECDC, and I want to say no less powerful with some technical glitches. Very powerful.
Sorry for that.
Very important. No need to apologize, obviously. But with these opening statements, let's proceed to the next section of our event. That is the section related to the state of evidence on behavioral science applied to antimicrobial resistance. And let's start this section by dwelling a bit on the core of this topic, that is the behaviors that drive antimicrobial resistance. And we're asking all of you to engage in this by answering this time slightly more detailed questions. So please open the Slido, and there are instructions here how to access it, and then think about the situation in your country and answer the question, to your knowledge, which behaviors are important drivers of AMR in your country. And you can select as many as apply, and I'm just going to read them out loud while you select which behaviors you wish to select. So the first behavior may be among physicians. They prescribe antibiotics for conditions that are not treatable with antibiotics. That could be a simple cold, could be a behavior with patients that do not complete their treatments. And it may be a behavior with some people who keep a storage of antibiotics to take when they feel bad. So they have a cold and they just take a few pills. It may be a behavior with the pharmacists who sell antibiotics over the counter with no prescription, or it may be hospital staff that do not adhere to personal infection prevention measures, such as hand washing or use of disinfectants, or it may be hospital management staff that do not ensure proper isolation of people infected with resistant bacteria. And of course, these are just some examples. There are many more. So you can also just select other. And then let's see where we're seeing the results. Clearly, the physicians prescribing antibiotics for conditions that are not treatable with antibiotics, like a simple cold. That's on the top. And then the patients not completing their treatment, followed by people keeping a storage of antibiotics. And of course, these two go together. So maybe you take half of your treatment and then you save the rest at home to have a few pills to take. But I also want to say that almost all of the behaviors are pretty high. The lowest one is on pharmacists, but also hospital staff and hospital management staff. Their behaviors also seem to be important drivers of AMR in the countries of the participants of this event. So, Hans, let me turn again to you, and you see the answers from the people in the room. What are your reflections on this?
So first, Katrina, I would like to thank Dr. Timur Sultan Gaziev for joining us here. Please send my very best regards, Dr. Timur, to the Minister, and thank you so much, dear Pamela, for joining us. The collaboration with ECDC is of capital importance for us because the challenge is too huge. So the reflections, Katrina, I would say, is that it's clearly everyone has a role to play, but we also know from the past, if we say something is everybody's business, very soon it is nobody's business because there's no accountability. So I think this accountability index will play an important role. Also, it are very stressful times for people, very stressful. So also medicines, we know that medicines in our region are the main driver to push people into poverty. So in that sense, again, I mean, this whole area, and you know, I'm a great advocate, a great supporter of the BCI, Behavior and Culture Insights, is very important, that we don't blame the people or the physician. I used to be a physician and a clinician, general practitioner in Belgium, and I remember that in the waiting room there were always representatives of pharmaceutical companies, you know, who were, I mean, obviously advocating for their particular drug. So we need to think evidence-based and then communicate very well and with a lot of empathy to everyone. Having said that, listen and learn from good practice. So here I want to thank Dr. Agnes, Dr. Olena, and Dr. Diane, who are going to speak. A lot is happening on improving behaviors in pharmacists. I think in the UK also in prescribing. So the carrot and the stick, as we say, and ultimately not forget about the elephant in the room, which of course is the consumption of antibiotics in the veterinary sector. Knowing how influential this sector is. I remember a couple of months ago when I was in Brussels, all these demonstrations from the farmers who was putting all the traffic to a standstill in Brussels. So we need to think from different sides, be ambitious, but also be very, very pragmatic. Thank you.
Thank you, Hans. And that is a really good point. And I want to say we haven't actually clarified that. Well, we are focusing on human health here today, but the animal sector is incredibly important. And it's the use of antibiotics among large household house stock, animal stock, that really is driving AMR in many countries as well. It's a really, really important point. And now, without further ado, please let me introduce the Vice Chair of our Technical Advisory Group on Behavioral and Cultural Insights, Professor Robert Böhm. He's a professor of psychology at the University of Vienna, and he's here to share his personal views on this topic, which I know he feels very strongly about. Please, Professor Böhm.
Thank you very much, Katrine. Welcome, everyone. My name is Robert Böhm, and I'm here to share three actually quite powerful points on the state of research related to behavioral and cultural insights on antimicrobial resistance. My key three messages are the following. We urgently need to know what works. And to know which interventions might be effective or not, we need to better understand the enablers and barriers of appropriate AMR-related behaviors, such as antibiotic use, for instance. But to know what works, we need to mobilize the research community and to promote collaboration across disciplinary boundaries. My third message will be, we are on our way, and there are already plenty of examples how BCI can contribute to AMR-related behaviors in this regard. The esteemed presenters before me have already established how critical behaviors are to mitigate AMR. Alongside, of course, other measures. Without a question, the accelerated spreading of AMR, as we see it now, is in large parts a behavioral problem. We do actually have an understanding of the enablers and barriers of appropriate AMR-related behaviors, including knowledge, attitudes, or incentives that are, of course, largely affected by the health systems. This is because, or identifying such interventions, building on such knowledge is very crucial. This is because the interplay of behaviors and AMR is quite complex. The same behaviors can have different determinants, and vice versa, different behaviors can have the same determinants. There are various stakeholders involved, and they are embedded in various different contexts. For instance, increasing knowledge about AMR, as already mentioned before, may not necessarily increase appropriate AMR-related behaviors, as people may lack the ability or the motivation to do so. Oftentimes, it's a combination of different factors that yield the most effective interventions. Our efforts currently are simply not enough. We need to explore this in much more depth and to gain much more detailed evidence of interventions with high impact. We need to measure their impact and to share this evidence globally. This is what actually made me start engaging in this field of research. As a behavioral scientist, I find it, of course, intriguing to understand the complex nexus of different factors and provide the necessary evidence. Additionally, I personally find it quite rewarding to contribute to addressing one of the most pressing health challenges of our time. This brings me to my next point, because you would expect that many researchers think like me, and the scientific community would be burning to contribute to this research field. As disappointing as it may seem, unfortunately, this is not really the case. We sometimes refer to this as the AMR research paradox. Although the study of human behavior related to AMR is connected to people's health and even mortality, AMR receives much less attention from social and behavioral science than many other health-related topics. In light of the current and the projected impacts of AMR on global health patterns, and also the critical need to understand associated behavioral drivers, the sometimes limited engagement of social and behavioral scientists in this field is, I have to say, alarming. Recently, a few colleagues and I initiated a network of researchers that wish to bring this apparent, or that wishes to bridge this apparent research gap. We identified 4 interrelated barriers to broader engagement in the social and behavioral sciences in understanding and tackling AMR. First of all, it's important to raise more awareness for the importance of the topic and the potential role that research can contribute to it, for instance, by creating educational materials. Yes, you hear me right, we do not only need to inform citizens, but also scientists to motivate them engaging in this important field of research. It is further important to define a clear research agenda for the social and behavioral scientists. This topic is so complex, and it may help to engage researchers if more specific and clearly defined research goals exist. This is something that I know the WHO and other organizations have worked on, and that we as researchers in the field are trying to specify and substantiate. For instance, what are the target behaviors we seek to understand and to change, and what evidence is already present, but what is also still unknown? We also need to build interdisciplinary collaborations, as it has been mentioned before. As a researcher in this field, I can say you that you can easily feel overwhelmed by the complexity of the problem and the many issues involved that fall outside of my area of expertise. National and international health organizations may support this by building interdisciplinary expert teams or by organizing interdisciplinary conferences and workshops. This is already related to my last point. We need to enhance the incentive structure. Even when we succeed in increasing social and behavioral scientists' intrinsic motivation to contribute to this important field of research, they may perceive it as challenging to change the research topics or even their whole research agenda, as it is difficult to change behavior with regard to antibiotic use. We therefore urge countries to provide more funding for research related to BCI and AMR. This is crucial because even potential medical innovations need some time, and we need to bridge this gap by promoting appropriate behaviors to mitigate the threat of AMR. And then, on an even more positive final note, my third message. We are on our way. BCI has proven to provide important insights and behavioral interventions already. There are many examples that I could list here. Let me select one of them. Prescribing antibiotics in case of acute respiratory infections persists. Although doctors are informed about it through extensive guidelines in many countries, there might be several reasons for this, such as patients' demand, defensive prescribing, and the interplay of such factors. In a large randomized controlled trial conducted in Los Angeles, researchers devised a simple intervention to target various of these underlying reasons at the same time. In the intervention condition, on the one hand, they ask doctors to sign a commitment that they would not prescribe antibiotics when it's not appropriate. Such self-commitments are well-known and evidence-based intervention concepts from the behavioral sciences. They then printed this commitment letter together with a doctor's picture and the signature in a poster-sized format and hang it up in the examination rooms, such that it could be seen by both the doctors and the patients. The idea here was that this may reduce the demand on the patient side, as well as increase the adherence to the guidelines on the doctor's side. This is due to the psychological need to be consistent and adhere to one's own expressed values. In the control condition, on the other hand, there was no such commitment posted. And indeed, in the 12-week intervention period, it was found that inappropriate prescribing reduced from initially 53% in the control condition to 34% in the commitment condition. This is a massive effect, considering how simple this intervention was. But I've already mentioned earlier that oftentimes we may need more complex interventions that consider the various determinants of AMR-related behavior. But what this simple example shows is that well-designed behavioral interventions that consider the underlying reasons of maladaptive behaviors and target these behaviors in the respective context can lead to substantial behavioral change. So in conclusion, we are on our way, but we are moving too slow and we can do much better. I want to call upon all of us here to work together to harness the power of behavioral and cultural insights as one of the important pieces in the puzzle to mitigate the threat of antimicrobial resistance. Thank you very much for your attention.
Indeed, and thank you, Professor Böhm, for this inspiring talk. I think it's clear that we still have some way to go before we're able to cross this gap between the different disciplines that really need to work together to address AMR-related behaviors. But there is a way forward, and you've shown that. And that was very inspiring. Thank you very much for that. And before we proceed, I just want to say that if you need a reminder of the acronyms we use, AMR and BCI, there are a few definitions in the chat. And I also want to say a warm thank you to Dr. Hans Kluge, our Regional Director, for joining us. You're leaving us for another, I would say, important meeting. You're off to a plane to Brussels to attend the second edition of the Global Health Diplomacy Dialogue. And I just want to give you an opportunity to say a proper goodbye to our event here before we proceed.
Thank you. Dank u schön, lieber Professor Böhm. I mean, it was a very, very interesting presentation. I myself, I'm learning every day on this very important field. So colleagues, I want to thank you for joining. I want to really give a lot of credit to Katrina for your leadership, to Rob, to the whole team. I'm very proud that in WHO globally, we are the team leading on the behavior and culture insights. And actually, this is something which will further prioritize, listening also to all of you. I wish you a good continuation and a very, very strong health. And thanks again to you, Dr. Timor, and to Dr. Pamela Rendi-Wagner, who we are awaiting impatiently here at our regional office in Copenhagen. Thank you. Dankeschön.
Dankeschön. Thank you. Merci, Hans Kluge. And now let's proceed to the next section of our event. And that is the one where we hear from countries about their experiences of applying BCI to AMR. And we will start with one more round of reflections from all of you. And we're still asking you to reflect on the situation in your own country. And we're asking you, are sufficient resources being invested in addressing AMR-related behaviors in your country? So are sufficient resources being invested in your country related to AMR behaviors? And we saw earlier that we asked, is enough being done at global level? And most of you said no. Now we're asking you, are enough resources being invested at local level? And it looks like you don't think the situation is any better there. We have 70% of you saying no to this question, which of course is discouraging, but I also think confirms what we've heard from several of our presenters here today. But the first country experience is actually one where some investment has been done in this field, so that is very encouraging and inspiring. It's Hungary, where a study was conducted to explore antibiotic prescribing behaviors among pediatricians. And there were some really interesting findings in that study. So to share these findings with us, please welcome Dr. Agnes Galgosci, who is the head of unit for infection prevention and control within the National Center for Public Health and Pharmacy in Hungary.
Thank you very much, Katerina. Good morning, everyone, from Hungary, from the National Center for Public Health and Pharmacy from Hungary. And I'm here to share a simple but powerful case example from our study. In the process towards adopting our AMR National Action Plan for Hungary, we explored the barriers and the drivers faced by pediatricians in prescribing antibiotics to children. Our study followed a rigorous qualitative methodology anchored in behavior change theory. The background for the study was serious. Unnecessary or suboptimal use of antibiotics can cause patient harm and is a leading cause of antimicrobial resistance. In Hungary, there was evidence of inappropriate prescribing practices, and two factors stood out. Children were the highest consumers of antibiotics in Hungary and were mostly prescribed broad-spectrum antibiotics. And the GP pediatricians and GPs in mixed adults and pediatric practices prescribed the most antibiotics per doctor. This made it clear that we had to explore prescription behaviors with pediatric GPs. Next slide, please. We decided to focus on a common condition where the risk of inappropriate prescribing of antibiotics is high: suspected respiratory tract infections in children. We conducted semi-structured interviews with 22 pediatric GPs with a variation across age, sex, geographical location, and prescribing levels. Results were rich and nuanced, but I will share here a few highlights. Next slide, please. On the positive side, the most GPs said they prescribe very few antibiotics, and some say they have decreased the use of antibiotics over the years. Most say they do not prescribe antibiotics for viral infections, and some mention specific symptoms that they use to preclude prescribing. They may instead refer children to diagnostics or recommend symptomatic treatment. The majority say they wait a couple of days from symptoms onset before prescribing antibiotics. Next slide, please. However, we also identified some issues and challenges. Laboratory blood testing, microbiological testing, or point-of-care testing were done only occasionally, and there was no standardization across the GPs. The main explanation reported was long turnaround times, lack of time during appointments, and lack of reimbursement for testing. Some felt they had sufficient experience to diagnose without a test, and the GPs emphasized physical examination as the main approach. They emphasized the need to treat children in their entirety. They wish to go beyond to the acute clinical manifestation of respiratory tract infections, and to also consider the child's personal medical record, social background, and the individual nature of each patient. Next slide, please. Such other factors to be considered sometimes included parents' preferences. GPs indicated parents could influence prescription behavior, for example, on economic grounds, saying that they are not able to take a sick leave. An additional factor driving prescription of antibiotics was the motivation to deliver effective treatment and also to avoid risk of complication for their parents. Next slide, please. The choice of antibiotics is critical because the more broad-spectrum antibiotics that are used, the higher the risk of antimicrobial resistance. And as I mentioned earlier, children were often prescribed broad-spectrum antibiotics. Overall, attitudes to the use of broad or more narrow-spectrum antibiotics varied considerably between the GPs. In other words, there is a low level of standardization across GPs for the choice of antibiotics. Reassuringly, many GPs reported using mainly narrow-spectrum penicillin for respiratory tract infection. Some said they wanted to prevent AMR by ensuring effective treatment from the start and therefore prescribed broad-scale antibiotics. This is, of course, a misunderstanding. It was also clear that, again, other factors play a role for some GPs in their decision-making. They might also consider the children's age, earlier treatments with antibiotics, and other factors. We found that most GPs were confident they applied the most effective therapy, even when prescribing antibiotics that may contribute to further developing AMR. Next slide, please. In fact, GPs generally came across as quite confident. Their strong belief that their experience grants them sufficient expertise to diagnose and treat respiratory tract infections could both be seen as a driver and a barrier. This confidence could be leveraged to encourage appropriate prescribing. But of course, in some cases, it also indicates knowledge gaps. Regarding sources of information, participants reported receiving information via conferences, continuing education, professional newsletters, and websites. But they also mentioned outreach from medical sales representatives, which reinforced the existing perceptions. Next slide, please. All in all, more prudent attitudes towards antibiotic prescribing seem to be common, but the study highlighted important issues that now need to be addressed. The close remaining gaps. Hungary will go ahead with the process to adopt our national AMR strategy and action plan and further increase our efforts towards support, communication, training, and feedback mechanisms to healthcare workers informed by the insights of this study. Thank you very much for your attention.
Thank you very much, Dr. Galgashi, for sharing these highly interesting insights from Hungary, which I think really very clearly explain and make it clear to us why changing behaviors isn't a simple, quick fix. It's really quite complex and it requires concerted effort. We've had some questions in the chat. Some of you have asked, are these presentations being made available after the event? And I just want to say that we are making a recording available of the event on YouTube very soon, so you can go back and take a look there. Before we proceed with the next country presentation, let's do one more round of engagement with all of you. This time it's not a poll, but it's a word cloud. And the question is, whose responsibility is it to advance the use of behavioral cultural insights to address AMR in your country? So basically, whose responsibility is it to use these more evidence-based approaches to address AMR behaviors in your country? Now, there are no answer options, so we're asking you to write your own. For example, you can put the Ministry of Health, and you can add as many as you see fit. And if you do not think that these methods should be used to address AMR in your country, please state not relevant. And then we will see how many people put not relevant in there. I think it's fair enough if some of you don't agree with applying behavioral science to AMR. So please just start putting responsible actors in there. I see a lot of words. And of course, Ministry of Health is a big one. Government, Ministry of Health, policymakers, UNICEF, ministry, community, GPs, pharmacists, veterinary sector, patients and populations. So I guess this in some ways just confirms what Dr. Kluge said earlier, which was it's not the responsibility of one person or one institution, but it's the responsibility of all of us and of many different people. And as he also said, this diffusion of responsibility may be what's making this very difficult, because we all have a role to play and all the sectors have a role to play. But clearly the Ministry of Health and the government, in your word cloud, stand out as really important stakeholders in this. So that was a bit on responsibilities. Let's hear from another country that is working to address challenges with AMR under really difficult circumstances. Dr. Elena Nestorova, head of the Scientific Research Department in the Public Health Center of the Ministry of Health of Ukraine. Please share your experiences.
Yeah, dear colleagues, hello. I'm very pleased and honored to be here and be able to present our current developments in Ukraine related to BCI and AMR and our intersection of those questions and approaches and when we are so far. And talking about that, I would like first to start describing the situation with antimicrobial resistance in Ukraine in general, and also related to our very specific conditions that were already mentioned before in previous talks. So first of all, I will talk about the situation with AMR in Ukraine, and I would like to start with 2021. It's definitely the problem started long before that, but I refer to 2021 just because on that year it was a first point prevalence survey made in 5 big hospitals in Ukraine, and that led us to assess actually prevalence of healthcare associated infections and showed that the level is like hundreds times higher than what is officially reported. And that was a remarkable moment that became a start of more close monitoring for healthcare associated infections in Ukraine. Another important part of this issue is that the monitoring of the usage of antimicrobial drugs showed that the level is not ideal, talking about the different types of antibiotics based on AWARE classification, and actually demonstrate that the usage of antibiotic and prescription that is not ideal and not actually rational, taking into account types of those groups of access, watch, and reserve. And Ukraine started introducing antimicrobial stewardship, but it was not implemented at the level we would want it to see that. And we also experience this rise of antibiotic resistance in different pathogens, namely in the such pathogens Klebsiella pneumonia, that is typical healthcare associated agent for those healthcare associated infections. And that's what was happening in 2021 and 22. But then, as we mentioned, we are having a very specific situation, and that is related to the ongoing full-scale war caused by invasion by Russian Federation and aggressive war led by Russian Federation against Ukraine. And that increases the challenge of the antimicrobial resistance. First of all, because we are having numerous, huge amount of complicated ones and many cases of infection and high infection rates related to specific war related events. And it's not like just there are so many injured military and also civil people due to the ongoing war. It is also that the current healthcare system is overburdened because of many reasons. First of all, because of huge amount of people who need treatment, and our military personnel, they are receiving healthcare in military hospitals and also in civilian hospitals, and they are there are specific route where people get this healthcare, and actually all healthcare system works to provide the healthcare needed due to that. But there's also a significant number of healthcare facilities that were damaged or even destroyed that also put additional burden on the healthcare system. And definitely the situation on the battlefield and the need to provide medical treatment to injured military personnel is a situation that you cannot always actually use antibiotics with testing. You need to start antibiotic treatment close to a battlefield as soon as possible sometimes, and it's not always possible to provide this testing and to use the rational antibiotic therapy. And there's a problem of evacuation and colonization by resistant flora on different levels, because the military personnel receiving healthcare, they are moved from one stage of evacuation to another. They receive treatment at different facilities, and this colonization happens on different stages. And we do see high and growing prevalence of AMR due to all those circumstances I mentioned above. And Ukraine is committed to implement modern approaches to infection control, infection prevention, and epidemiological surveillance based on all the modern approaches, and further introduction of antimicrobial stewardship program, and also development of a new national action plan. But it is all complicated with all the circumstances that I mentioned before that. I would like to talk a little bit more about the BCI approach separately, first of all, from AMR, because we started to incorporate it, let's say, from 2023, when we first heard this abbreviation. And I was nominated as a focal point for BCI in Ukraine and attended the meeting by the WHO Euro, and I've heard in details about the BCI and also the combi models that I will mention further. And we decided that we are committed to use this approach. And just to mention that we already implement that partly because we do perform behavioral studies related to different healthcare questions to provide information for health and public health programs. But here we have it more structured. We are learning, and we had several sessions, learning sessions. We had in-person session from Euro WHO. For us, we also attend online sessions and webinars, and we are having coordination with WHO Euro and WHO in country office with that, and having also some plans to have this focused initiative related to the BCR. And we decided to implement the combi model to our studies related to any barriers and facilitators of different programs. And we started actually with BCR, and now we are having ongoing study of antibiotic prescription practices among hospitals in Ukraine. That is funded by our founder and partners, Norwegian Institute for Public Health, and it's implemented together with WHO Euro and also involved with the WHO country office. And we do apply this BCR approach, namely the combi models that I will mention. So our expectation here is that we are want to get some insights from this study, that now the data collection is ongoing. We perform it in big cities, and now we go deeper in smaller, like in a local level, in smaller settlements, to know the situation differs there. And we are planning to get information to develop recommendations to address specific barriers that we hope to describe based on this study. And also we plan to disseminate funding and recommendation and raise awareness about antibiotic resistance based on the specific information we will get. And we do use the combi models that I mentioned there that addresses capability, opportunity, and motivation. And for capability, we want to study in depth the knowledge gap related to antibiotic prescriptions in hospitals, on opportunities talking about barriers specifically to access resources, and the motivation talking about trust and guidelines and to institutional management, and to describe it in details to get the results I mentioned above. So our vision here is actually that we are planning to expand these BCI initiatives, talking about this AMR program, but also in other areas of public health. We do need to build our expertise and capacity building, and also strengthen interdisciplinary collaborations that we already have in the study that I mentioned. And if just summarize what we are having so far, so we do have a key BCI initiative initiated here, namely the AMR study, and we have a strong collaboration with WHO and with our international partners, namely Norwegian Institute for Public Health and others. And we are hoping to get further support in development of this area. As I mentioned, we are committed, and we see our closer collaboration with WHO Euro BCI unit and the local BCI responsible person from WHO with AMR team and with all the stakeholders involved. So thank you for your attention and the opportunity to present our progress so far.
Thank you very much, Dr. Nestorova. And of course, the commitment on our side to support you is unwavering. Thank you for a thought-provoking presentation. I think crises do have a way of proliferating existing challenges, and it's a good reminder to everyone in the room that we do need to consider how we can address important challenges such as AMR during more peaceful times so that we are ready whenever there's a crisis. We continue on with our country examples and the last speaker of the day before the optional Ask the Experts session. The United Kingdom is applying an interdisciplinary and strategic approach to AMR-related behaviours, and Dr. Diana Shiro-Oradopa, lead pharmacist of the UK Health Security Agency, is here to tell us more.
Thank you very much. Just checking you can see my slides okay?
Yes, we can.
Excellent, thank you. Okay, good morning, everyone. Really, it's an honour to share with you today our journey so far in England, in the United Kingdom, on using behavioural insights and sciences to tackle antimicrobial resistance. I'll start off by saying that I'm a pharmacist and working alongside and learning from behavioural science specialists and health psychologists over the years. I have been able to personally embed use of behavioural insights across the work programmes and interventions I lead. I say that because it links back to the question and the slide that we had earlier about who's responsible. So our journey started in 2013 when we conducted a national review of the literature to assess available evidence about key behaviours that support antibiotic stewardship across three important constituencies: the public and patients, the primary care and secondary care. When we conducted the behavioural analysis, we also then used published frameworks which are available for behavioural science within behavioural sciences. And in this case, we used the theoretical domains framework and the COM-B model. I would say not to worry so much about what those mean, but it's more really just sharing with you that we did use specific frameworks and use behavioural frameworks. This helped us to identify key intervention opportunities, targeting the public and patients and healthcare professionals, but particularly around general practitioners. For general practitioners, we realised from the evidence that one solution was to address their concerns about the consequences of not prescribing antibiotics. And also then for the public and the patients, the importance of making the risks of AMR more immediate, visible, and then personally relevant to them. We also recognise the importance of enhancing the credibility of pharmacist advice and patients following that. The literature review was published on our national government website. And at that point, it stated that it was not government policy and it didn't commit any organisation to a particular course or of action. However, it signalled a direction of travel and it catalysed significant action across our public health agencies as well as other health institutions. As I mentioned, since 2013, as a result of that publication, the literature review, the behavioural analysis, and then the publication, there have been significant actions taking place. And we've had numerous interventions now published and developed, which have used behavioural insights and behavioural insights to develop them, to implement them, and also to evaluate them. Whilst I cannot cover all of them today, I wanted to highlight a few of them to you. One example is the letter that was written by the Chief Medical Officer for England at that point to the general practitioners, the family doctors, who had higher than average antibiotic prescribing rates. This personalized approach successfully raised awareness of antimicrobial resistance with those doctors. We also launched a campaign for the members of the public who didn't even know why they should care about antimicrobial resistance. And that campaign again built on the evidence we had from our behavioral analysis that we did in 2013. And what that campaign focused was on showing the consequences of antimicrobial resistance and making it personally relevant. Further updates to our eBug platform, which is for children, has really focused on using behavioral, on changing and catalyzing positive behavior change amongst children and young people to support infection prevention and control and to tackle antimicrobial resistance. eBug is available in multiple languages. And our target toolkit again uses behavioral insights to develop that, to provide resources and tools for general practitioners, pharmacists, and pharmacy technicians, as well as members of the public. We have also assessed healthcare workers' knowledge, attitudes, and behaviours and practices around AMR. One more to highlight is our AMR indicators platform, which publicly provides data on a range of antimicrobial indicators from anywhere in the world. People can access that at regional level and hospital level. And some of those data include antibiotic use, infection prevention and control measures such as vaccination rates. All these interventions have been rooted in developed using behavioral insights and sciences. I now want to focus particularly on one case study, which is the Antibiotic Guardian campaign. The Antibiotic Guardian campaign was launched first in 2014 as a national campaign, but it soon expanded to be a global campaign when we realized that colleagues and individuals were choosing their pledges from across the world. And then we had collaboration with WHO Europe and Africa CDC, as well as a number of other countries. The campaign uses a behavioral approach called if-then implementation intentions. And what this does is a self-regulatory strategy where you give people you get them to commit or to highlight what they would do in particular situations. So it gives, for us in this, we have actionable pledges for individuals to choose from. One example is, if I'm prescribed an antibiotic, I will take it exactly as prescribed and I will not share it with others. That's just one example. Well, we have tailored pledges across multiple groups. We have pledges for healthcare professionals, and you can see a range of those healthcare workers that we have pledges for, very tailored to them, including public health specialists, nurses, veterinarians and the vet nurses, farm advisors. And then for members of the public, we have pledges for pet owners, as well as those with family members. And then we have pledges for students, educators, and scientists as well. I highlighted that the Antibiotic Guardian campaign has really been an opportunity to catalyze action. And what you can see on this page is just a range of examples of what's happened across communities, childcare centres, community pharmacies, companies, and as well as senior leaders choosing a pledge about how they will personally keep antibiotics working. We've evaluated the campaign, and the evaluation has shown us that there is increased commitment from those healthcare professionals and members of the public, and that people reported increased knowledge or greater knowledge and changes in behaviour, self-reported, particularly amongst those who already knew about tackling antimicrobial resistance. More recently, we did a strategic, again, behavioural analysis of all our national antimicrobial stewardship interventions in primary and secondary and community care, just to understand what interventions we're mainly using. What we saw was that training and education and enablement were mostly used. But we know that we need to go beyond that. And so we've started to think about other behavioural interventions that can really catalyse and further increase our progress. So now I'm going to, in my next final slides, I want to share with you where we've now moved to with our National Action Plan. Our recently published National Action Plan, which is a UK-wide National Action Plan, which is published in May and takes us through the next 5 years, places social and behavioral sciences at its core. Of the 9 outcomes and 30 commitments within that, many specifically highlight and include the need to embed behavioral science, particularly for public engagement and stewardship efforts, but also as well in infection prevention and control, as you can see there where the red highlighters are. These next couple of slides just show you the text taken verbatim, copied from the National Action Plan. And you can see there where behavioral factors are mentioned, the use of behavioral interventions, individual behavioral actions, that we will use and apply evidence, including social and behavioral sciences. These are taken from the National Action Plan on AMR. And again, more here, understanding the social and behavioral factors, and then including targets focused on behavioral outcomes. In addition to those that I highlighted earlier, we have 5 targets across human health, and we also have targets for animal health. And they clearly highlight the importance of using that those support our behavioral interventions that we want to have nationally. So policy interventions around having targets. We also, in the National Action Plan, identified 10 research priorities. And one of those is specific around behavioral public awareness and behaviours and antimicrobial resistance. So in conclusion, our journey embedding behavioural insights started in 2013 at a core level with an evidence review and behavioural analysis, which has then catalysed action, not just within the national and the government agencies, but across several organisations nationally. And this has resulted in our approach to developing, implementing and evaluating interventions to tackle antimicrobial resistance. It is now a fundamental part of our national policy as is reflected in our current National Action Plan on antimicrobial resistance. Thank you.
Thank you very much, Dr. Ashiro Oradopa. I think the work that you do in the UK is indeed inspiring, and it brings hope that we can all work in a more interdisciplinary manner to address the threat of AMR and address AMR-related behaviours. And now, as we have heard from all of our excellent speakers, we have one more question for you as the audience, and dare I say, a tricky one. The question we have is, in the future, 10 years from now, do you think we will have been successful in reducing the threat of AMR globally? So I'm not asking if you think we have removed the threat of AMR, but will we have been successful in reducing the threat of AMR? And I'm seeing a 50-50 vote. Answers are coming in, but we're seeing yes, taking the winner's seat, but still around 40%, 44% say we will not have had success 10 years from now, which of course is discouraging, but I am happy to see after this event here today, where we were trying to look at a way forward, that, that the majority in the room have some hope for the future. And of course, I mean, the overall question may be, do we have a choice? Do we have a choice not to act now and not to be successful over the next 10 years? To maybe answer that question, to reflect on the question and the answer that we got, and also to maybe summarize some key points from our conversations here today and point to a way forward, I would like to hand over to Dr. Danilo Lofo-Wong, the Regional Advisor for the Control of AMR here at WHO Europe. Danilo, please share some reflections from your desk.
Thank you very much, Katrine. And first of all, I'd like to say I've really enjoyed all the speakers and all the things that have been coming up so far. I actually, together with the regional director, I am also a born optimist. So 10 years from now, actually, I will retire. So I do hope that we have made some good progress by that time. I don't think we've ever seen this much attention for not only antimicrobial resistance, but also more and more upcoming for behavioral and cultural insights, which also is, is very, very good for us because we've been looking at it for quite some years. We've had some good examples and good experience working with also some of the countries that provided their examples here today. But of course, much more needs to be done. But it was very, as I mentioned, inspiring, but also I think we made a compelling case of how to move forward, because lots of the things we already do know, the kind of interventions that we need, and we do know that awareness itself is not enough. We do need to understand behavior in order to change it for the better. So, and I think the presentations we saw today made a very, very compelling case for that. Very, very thankful for the presentation by Robert Boehm, who we look forward to work more closely with on that. We are on our way, but of course we need to accelerate together. I think we all agree that we need to understand behaviors, as I said before, because behavior is a crucial driver, but should also be a crucial solution to the AMR issue. We have to involve more people that understand the behavioral side, but also people that understand the AMR side of things. And it was very, on the one hand, very good to see that there are many people here that at least indicate they know something about the topic, but it also highlights that some of these important events as today need to go beyond the AMR community and beyond the BCI community. So we all have to be ambassadors in a way of the interface of the two disciplines and try to recruit more people into this space. I think also from the beginning, we heard a very strong commitment, both from our regional director and from the director of ECDC, that AMR and behavioral insights remain a priority, and hopefully there will be more investment in these topics in the future, so we can actually start making this progress. But most of all, very happy with the examples that were provided today, that things are already ongoing, that we can learn from, and actually finally hammering home the message that we all need to consider our own behaviors, especially when they affect others, and we're in this together. So I agree, there's no alternative but to address antimicrobial resistance. Thank you, Katrina. Back to you.
Danilo. So there seems to be a way forward, but a lot of work ahead of us. So let's get started. Before I close this formal part of our event and proceed with the optional Ask the Expert session, we do have one last question for all of you. But this time, we're not asking you to share your answers with us. In behavioral science, there's a well-known concept called the intention-action gap. So put simply, we humans can be very motivated to do something, we really want to do it, and we just never get round to doing anything about it. I bet there's not one person in the room who doesn't recognize that feeling. But one way to overcome this intention-action gap, and there's quite strong evidence to back this up, is quite simply to write down with as much detail as possible what we want to do, when, where, and with whom. So that's what we're encouraging you to do now in a few minutes' time, to find a pen and a piece of paper to answer the question for yourself based on what you've heard here today. What actions will you personally take in the next 3 weeks? However, before going ahead with this exercise, I just want to thank everyone for joining here today. Thank you for the inspiring and thoughtful presentations and the speakers. Thank you to the audience for playing along with the polls and the reflection questions. Thank you to the BCI and AMR teams here at WHO Europe for organizing this together. And I'm just going to mention the names because a lot of people have worked really hard to put this together. Tina Licky, Sandy Neal, Danilo Lofo-Wong, Ketty Kandelaki, David Barrett, Leslie Belsberg Hansen, Marie Wolf, Suhuyini Sayubu, Torgun Isa, and then our ever-supporting management, our director, Rob Butler, and of course, our regional director, Hans Kluge. Thank you to everyone for putting this together with me. We hope all of you in the audience have found the session inspiring and that you will continue to work together to address the threat of AMR. It is really very much needed. And if you would like to hear more, if you have any questions for any of our speakers, it's really quite simple. Please just stay on for another 2 to 3 minutes and we will continue. And at the Ask the Expert session, we will be joined by Danilo Lofo-Wong, you've just heard from him, behavioral scientist at WHO Europe, Dr. Tina Licki. You haven't heard from her, but she's been a driving force in planning this event. And also we will be joined by experts from the ECDC, Dominique Monet for questions related to AMR, and John Kinsman for questions related to behavioral insights. And with this, we're now encouraging everyone to pick up a piece of paper and take notes on your actions related to AMR and AMR-related behaviours during the next 3 weeks. Please be as concrete and detailed as possible, noting down when, where, and with whom. And with that, I want to say a very warm thank you. Welcome back to those of you who decided to stay on for the optional Ask the Expert session. If you have a question, please just raise your hand and I will just ask Tina Licki to alert me if anybody does that, because I'm not sure I can see everybody and everybody's hands on all the pages. You can also post a question in the Slido Q&A function. So you can go back and see the instructions on how to get into the Slido. And in that, you can actually vote for questions that others put in the Slido. So we have a democratic way of deciding which questions to answer and which questions to answer first. And we do have some questions already in the chat. I have the overview here. And one of these questions has been voted at the top. And it's public awareness keeps being mentioned. But do we have good evidence that this should be a priority target to address antimicrobial resistance instead of prescribers? So is public awareness an important topic? And I would like to ask first Tina Licky and then Robert Boehm to reflect on that question.
Thank you, Katrine, and really nice to see everyone and so many people joining our event this morning. I think the simple answer is public awareness is important. It's mentioned as one of the key areas of the WHO Europe Regional AMR roadmap. But of course, that's one part of the puzzle. I mean, we need to address both. It's not either or, patient demand or prescriber behavior, but it's both. But I'll let colleagues continue, Robert and Danilo.
Yes. So, so the clear answer is yes. Yeah, awareness is important, and also knowledge is important. Yeah. So we've heard this earlier. The Eurobarometer shows that there are increasing trends in knowledge, but what we also see is there are huge differences, and knowledge is a central driver of attitude formation. And so increasing knowledge about the potential negative consequences of accelerating AMR is very, very crucial, and also where you would not expect it, namely in terms of prescribing. So we know that patient demand is a strong predictor of actual GPs prescribing of antibiotics. So yes, it is not the only factor, but it's a very crucial factor to fight AMR.
Thank you, Robert. And that was actually one of the key findings from the study in Hungary that we heard from Dr. Galgoshi earlier on, that the pediatricians sometimes prescribed antibiotics based on parent preferences. So this is a real thing, that the pressure from patients can actually affect prescriber behaviors. We have a second question that has been rated high on our list. And as I said, if you have a question, please just put it in the Slido Q&A function, and you can also vote for your popular questions there, or the questions where you'd like to hear the answer. So the second question is, what should be the main policy strategy that should be implemented at an EU or global level? And I would like to direct that question first to Dominique Monet at the ECDC, followed by Danilo Lobo from here at Europe.
Thank you very much. Good morning. The policy, well, the actions that we need to implement will always be a bundle of different policies that will address all the different actions, in the same way that what we've been presented as a national action plan for a new national action plan for the UK. The EU actually and the ministers of health approved council recommendations recently. That was in June 2023, and all the policies are in there. If I summarize, we need to be better at being prudent at using antibiotics, and at the same time be better at prevention and control, or I should in general, better hygiene. And we need to do not one or the other. We need to do both at the same time. Thank you.
Yes. Well, first of all, I completely agree with what Dominique just said. It is, of course, a package of multiple policies. What we do think is it has to sort of be a combination of, I guess, bottoms up and top down. As we mentioned before, we were talking about informing the public, informing the health workers, but also on the veterinary and agricultural side about best practices. But also what we've seen is that, for example, for a long time in the EU, countries have not been able to get antibiotics over the counter, which in another part of the region, unfortunately, is still possible. So there has to be not only legislation, but there also has to be reinforcement of that legislation. We've seen some horrible trends during COVID-19, for example, that if you could get antibiotics, you would, of course, go for these wonder drugs that have been helping us for almost a century against pretty much anything that is at least the popular belief. So I would say bottoms up and top down approaches through policies, through enforcement, but also through awareness. Thank you.
Very much, Danilo. And if I can add from my side, I think it is about important documents, but it's also about implementing the documents that we have in place. So a year ago at the Regional Committee for Europe, all of the member states adopted a new roadmap for the prevention of AMR, which had a very clear focus on people-centered approaches and clear prioritization of behavioral cultural insights. So I guess some of the important documents are in place, and we need to start working on implementing these documents. All right, the next question we have here is, why are there so few antimicrobials in development by the pharmaceutical companies if AMR is such an important problem with high mortality? So I'm just handing over again to you, Danilo, if you would like to reflect on that, and potentially also Dominic again for a few reflections on that question.
Thank you, Katrina. It's a good question, and it's been asked many, many times. But unfortunately, antibiotics they are quite a cheap medicine. So the profit margins are very, very small. It's very difficult to develop new antibiotics, which requires a lot of investment, and it's a very, very long pathway. And the problem is that people like us will say, well, if we have a new antibiotic, we really advise you not to use them, only in the very, very sort of last resort cases. So there's not a big market for it. There's a lot of costs in development. And yeah, basically it's just very, very tricky to come up with new or really new antibiotics. Because of course there are some antibiotics coming to the market, but they're very close to what we've seen before, which also means that the pathogens out there will quite soon become resistant to them as well. So it's it's also an issue of a sort of a broken business model, unfortunately.
Dominic, did you want to add anything to that? So again, we have some issues. You're muted, Dom. Right.
There are new antibiotics.
Now I'm hearing you.
Everything seems to be in place here. Okay, thank you. There are new antibiotics that are now marketed that have an activity on multi-drug resistant bacteria, gram-negatives that are resistant, including to last-line antibiotic, the carbapenems. And the sales are increasing. The data show that the sales of these antibiotics are increasing globally. But obviously, the amount of sales is not enough for the pharmaceutical industry as per the current model. So it's not that there are no sales. There is a public health need for treating infections with, I would say, extensively drug-resistant bacteria, and the antibiotics are used. But obviously, those sales are not enough as per the current pharmaceutical industry model.
Thank you. So here's a question about country work. How can countries get more insight into the key relevant AMR behaviours and related barriers and enablers for their specific context? How can countries get more insight into the key relevant AMR behaviours and related barriers or enablers for their specific context? So I'm going to ask Tina Licke to reflect on this. And then while Tina reflects, if we have all of our three country speakers, Agnes, Diane, or Lena, if you would also like to reflect, please just unmute after Tina, and then I'd like to hear your answers as well.
Thank you. So I think we've heard great examples already today of how this can be done from the countries. But at the heart of this is really data. Again, on behaviors, we can look at data that's already collected, especially for prescribing. This is often already in the electronic format that we can access, and we can see how much is actually being prescribed and what. And when it comes to patients, the patient aspect, this is something we can ask people. And I think this is where BCI really comes, in behavioral and cultural insights, comes to the fore, in that it offers very robust and systematic methods, whether they're quantitative around surveys or qualitative, where we're actually digging a bit deeper into what the barriers and drivers are for specific groups that engage with AMR-related behaviors. So it's an investment. I guess that's what it boils down to. It's an investment in really wanting to understand rather than rely on assumptions about what drives behavior.
Just looking to see if Diane or Lena or Agnes would like to add something to this.
Thank you. I can just add very briefly. I think having data is really important, as Tina has mentioned. And I think not only just having that data, but sharing that data is important. In terms of which particular ones are most effective, I think it will really depend on the context. And so it really is quite challenging to say one over the other, because it will depend on what groups you're targeting and then what works for them. So really looking at the evidence is going to be important. Then using data, sharing that data. We've used a package of interventions across the UK and in England, within the UK, as well as all the other nations. And what we're finding is that we are seeing that reduction in antibiotic use is perhaps not as much as we would want to see, but there is a shift. And obviously we had the pandemic in the middle of all of that. But definitely we know that before we started looking at our data and sharing our data nationally from 2014, we were on an increase, a significant increase in antimicrobial use. And since then we've been seeing reductions and stability. So I think data is really important, but which particular one will be most effective will depend on the context.
And congratulations on that sort of shift in trends, which of course is really important. And I'm not sure how many other countries are seeing that positive shift in trends. So I wanted to bring one more person into this discussion, John Kinsman from the ECDC. You may want to reflect on the same question, or if you feel enough has been said about this, there's another question here, which is, are there any data that shows which behavioral change theories proven to be most effective? John, do you have any reflections on this question?
On the hop, I can have a go. I mean, I think the thing with the theories is no theory is perfect, but all theories have something to offer, and it really depends on how you want to look at the situation. COMBI has been mentioned as a very good overriding model, which provides a way of looking at things from the point of view of capabilities, opportunities, and motivation. And it's a very, very nice rounded approach, which takes into account specifically the individual, but also the broader context. And I think that's very, very important. Models that only take into account the individual behavior may be somehow lacking and may be missing some of the factors that influence people to make their own decisions. So I think whether you use one model or another, I think overall the important thing is really to try and make sure that you take into account the individual and also the things that are going on in the outer world, which will actually affect a decision-making process, perhaps unconsciously in that sense. So something which would be relatively multi-level would always be good. So COMBI is a good one.
Very much, John. And we have one more question, which I think is almost a follow-up question to what you said earlier, Robert Boehm. So I'm going to direct this to you. What are the effective evidence-based approaches to managing patient pressure for antibiotics? So the evidence-based approaches that are proven effective for managing patient pressure.
Can you hear me? Yes. Okay, so I mean, there are various factors related to that, and it's really difficult to come up with rankings because this requires meta-analytic evidence, and we rarely have that. So again, although we always say knowledge is not everything, if you think about what is the single most important predictor, it's still attitudes and knowledge. Yeah, no question about it. It's not sufficient, and barriers may actually increase the gap between what people know and what they want to do and what they actually do. Yeah, so intention behavior gaps, and therefore we need to address that. But if you think about the single most important predictor, it's the attitude of people. Yeah. And so if you come to a GP visit and you have a strong assumption that you want to have an antibiotic prescription and you make pressure on that, so that is clearly driven by your a priori knowledge or by your attitude.
Right, so the next question may be for you as well, Robert, but I'm inviting everyone in the expert panel to chime in if you have an answer, because it's a difficult one, but it's been voted as the most popular question, so I'm just going to ask it. Has there been research on the best individual approaches to prevent AMR, other than appropriate antibiotics? For instance, vegetarianism, hand washing, and so on. So what is the best individual approach to prevent AMR? Could that be vegetarianism, hand washing, or appropriate antibiotics? And this may be for you, Robert, but it may also be for Danilo and Dominique to say what is the most important thing we as individuals can do to reduce the threat of AMR?
From my perspective, I have to say I'm not aware of any evidence in this regard. So there is some evidence about what is actually the role of behavior at all, yeah, in general, compared to other things. And there we know that behavior, as so related to AMR, right, the accelerating spread of AMR. And there we know that both individual behaviors, so human behaviors, as well as prescriptions in the animal sector, these are the two most important predictors of the spread of AMR. But if we focus on one level further down, so which behaviors, I'm not aware of any good evidence of ranking those different predictors. Yeah, this is something we could work towards in the next years. But maybe the others correct me. It's not that I know of.
It looks like Dominique may have some reflections on this question.
First, common sense. Okay, if we're on a bus and we're putting our hands everywhere, on the metro, on the public, on the escalator, electrical stairs, yeah, sure, it's a good idea to disinfect your hands when right after you will be entering the office and start typing on your keyboard. Just common sense. And we know that not taking antibiotics when they're not necessary also prevent us from an exposure to antibiotics. And we know that the resistant bacteria created by this single exposure can be in our body for 6 months, sometimes a year. So these two things are obviously common sense. Eating only vegetables. There have been studies trying to look at food and resistant bacteria in the digestive tract of people that just eat vegetables and organic vegetables, and the one that don't use, eat all kind of food as we are as humans. And it seemed that in the organic foods, there are less pesticides, but when in terms of resistant bacteria, it's about the same as other foods. So by eating organic food, we protect ourselves from the pesticides, but not necessarily from the resistant bacteria. And there are studies, but I've not seen any review of the evidence so far.
Thank you very much, Dominique Monet from ECDC. So we have 2 more questions. Oh, Tina says there are raised hands.
I raised my hand to contribute, but if we need to move on to another question.
Thank you. Go ahead.
Thank you. I just wanted to very briefly reflect on 2 questions that are in the list that are connected. One is about managing patient demand, and the other one is responding to the general practitioner's concerns. And these 2 are obviously linked, and I'm not sure if we really covered them already, but partly what Robert was saying is that if we can change attitudes within the patient, then they're less likely to demand. But if the situation's already happening where the patient's in the GP's office, they're requesting the antibiotic, I think this interaction is a key part where there's some emerging evidence, including by Robert's research group, that looks at essentially empowering the GP or the prescriber to have a constructive conversation with the patient that reduces the patient demand. And this, I think this needs to target multiple things. One is the GP's own understanding of AMR. So their sense that this is a problem, their understanding of it. Also their sense that they have something else to offer. So they're feeling that they're not just sending a person out without nothing. So this is the antibiotic-free prescription leaflet that is developed by Danilo's team, that is available on the web, that we're looking to further tailor and assess, which is really provides this kind of concrete tool. So I think it's that interaction. And of course, there's always a health systems perspective, which is if the GP is concerned that this patient will leave and will switch GPs and they will lose income if they don't prescribe, that's a systemic structural factor that needs to be addressed at another level. Over.
Thank you very much, Tina, and thank you for covering a few questions in one with your answer, because we are coming to a close and we have one last question, and I'm just going to throw it out there and ask if any of our experts would like to reflect on it. It's almost a philosophical one, but it's the one that is the most popular at the minute. Could we consider adjusting our strategy to focus on learning from microbiotics rather than trying to combat them, fostering a more collaborative coexistence? So that's the philosophical question that we will end with today. And I'm just going to throw it out there and ask if any of our experts would like to reflect on this.
Katrina.
Yes, please.
I'm not sure how much you can see hands and all that, so I'm just going to throw it out there. No, I think this is an excellent question. And of course, it's not just philosophical, but it's also essential, because we talked about narrative before, and the narrative, which we're changing away from a little bit, luckily, is this sort of war rhetoric. We're combating antimicrobial resistance, we're fighting, and we're, the thing is that microbes have been here before us, and they will most likely also be here after us. So I think this is definitely a venue that we need to work on a little bit more to see how can we coexist, and also how can we, as humans, become better at resisting infections, better at basically living with microbes, because there are so many of them, and most of them are actually very useful, but they tend to have a bad name for this subpopulation that makes us sick. So we need to both focus on the good ones and try to control the bad ones. Oh.
Thank you so much, Danilo. So with this appeal for peace between us, I think it's a very good place to end this Ask the Experts session part of our regional committee side event today. I am aware that there are quite a few questions that we weren't able to answer. We're simply running out of time, but don't despair. We will find a way of answering your questions. There's an email address in the chat. So if you have an important unanswered question, then just send it to that email address and we will find a way of responding. Some of you may also have specific questions to the speakers here today, and then we will forward your question to them. A warm thank you to our experts in this session. A warm thank you to everyone who listened in and who stayed until the very end. A warm thank you to everyone who engaged actively, to those who asked questions and who voted for the most popular questions. Thank you from me, Katrine Bach-Habersold, and thank you from all of my colleagues working with BCI and AMR here at WHO Europe. We wish you all a wonderful day.